Yeah, no worries.
All right, good evening, everybody. Thank you so much for coming tonight. Welcome to the South Sound Study Club. I'm Kevin Suzuki, one of the partners at Puget Sound Orthodontics. Just a couple of announcements real quick, and then I'll introduce our main feature tonight, Dr. Ben White, who we're all very honored and blessed to have here. Make sure that you fill out your name if you want CE forms. There should be one at each table. There should be some pens scattered around. We'd really appreciate it. It helps us keep our accreditation up to at the end if you could fill out a survey. You don't necessarily have to put your name on it, but it just helps us to kind of keep a record and to get feedback on how to make things better, even if it's something minor like the food needs to be better. So any feedback is appreciated. Also, our next meeting here will be October 17th. We have Michelle Caldier coming. So she's going to be giving us, I think, an update. And she'll be spending some time with all of us. So now it's my privilege to introduce Dr. Ben White. He just recently had joined the community about a year and a half, 2 years ago.
About a year and a half ago.
About a year and a half ago, he first practiced from Dr. Camille Vandevanter. I have to say I've been very impressed with him. I was one of the first doctors that was fortunate enough to be able to meet with him and have lunch. We got tacos. So he's very humble. He's very intelligent. I think he does really great work. Just a couple of credentials before he starts speaking. He got his DDS degree. He was magna cum laude from the Medical College of Virginia. He was also an OKU member. It's only about, I think, 5% of dentists get that in the class. So really impressive there. And then he went on to do orthodontics. He got his Master's of Science in 2003, and that was from Indiana University. And so he's been practicing. He's actually continued on as well with very prestigious institutes like the Pankey Institute, I understand. Mm-hmm. And so he's a lifelong learner. So we're very blessed to have him here tonight. Thank you very much, Dr. White.
Yeah, thank you for that warm introduction, Kevin. I really appreciate being here. Thank you. Thank you. Oh my gosh, thank you. Really appreciate Kevin and Tom's invitation to speak today. And both of these guys have been so gracious in welcoming me to the community. It's wonderful. I mean, just great docs and a great group of people here in Federal Way and in the South Sound. And just wanted to start with a brief introduction about who I am and kind of myself, my wife, my kids. So together we have 5 children. To my right, which would be the left-hand side of the screen, we have Ethan, who is 16, who is a junior at Peninsula High School. We have Nolan, who is 19, who is a brick mason apprentice, probably one of the only smart kids in the entire family. And then we have Nakia, of course, to my directly to my right. And then over to my left, I have my children. I have a 14-year-old daughter, Jocelyn. I have a 24-year-old son, Connor, who is a technical writer. And then I have an 18-year-old son, Bryson, on the end, who is currently serving a church mission in the Philippines. And then if any of you guys know us in our office, we have a dog that comes to our office. This is Brody. He's our 4-year-old golden retriever. Some of the things that we enjoy doing: travel, hanging out with the dogs. We do root for the Padres, but they're a National League team, so it's okay. We do enjoy just being silly and funny. All of my kids really enjoy sports. My daughter is an artist. This is us doing an escape room, and we did not escape on time. We failed that. There's Nolan again, really involved in his church, and then Ethan, who's trying to figure out how to be a 16-year-old. This is our dog Brody, the dude, and Nakia and Brody. And if our life wasn't complicated enough recently, we got another puppy about, in June. So our life has become a lot more complicated with this puppy. Today, what I'd like to do is I'd just like to talk about clear aligner therapy, and there are some other things. I'll give you some tips and tricks. I wanted to talk about this because so many of you have scanners in your office, and there are so many of you that are currently looking at doing clear aligner therapy or are currently doing it in your office. Doing a tooth movement with removable appliances isn't anything new. In 1945, Harold Kissling invented a removable rubber appliance that looked and functioned like a night guard. So this is a tooth positioner. It was generally used as a finishing appliance. And when I was in residency, what we would do is we would use these appliances on our cases that we considered board cases, or we would use the appliance on patients that we wanted to bail out on treatment. Weren't cooperating with elastics, they weren't cooperating with keeping appointments, whatever it was, hygiene was poor. And so we would deband these patients and we would send the impressions or the molds to a lab. Lab would fabricate a tooth positioner. The problem is, of course, is if a patient's not going to cooperate during orthodontic treatment and brush their teeth, they're not going to wear this giant mouth guard, even if it has these 3 air holes. And then what's happened is there's been a transition in orthodontic retention from basically acrylic appliances, Hollies, to thermoplastic retainers made of polypropylene, polyethylene, or PVC. You of course can use these to move the teeth. You can do it by resetting some of the teeth on a stone model. You can make modifications to the model by removing some of the stone and then blocking out the other side. Or you can use a dimpling plier in order to provide pressure to help rotate teeth. So an example of that, we've got a gal that had braces before, wasn't really diligent about wearing a retainer. And so a reset Zendura retainer was made in order to move those teeth forward. So really, really simple tooth movement, really predictable. So in 1996, Stanford University student Zia Chisti, who happened to be an MBA student, was wrapping up treatment with traditional brackets and wires. When the braces were removed, clear thermoplastic retainers were given to retain the orthodontic correction, and this got him thinking, maybe we can use these clear plastic trays to move teeth. And so Chisti recruited some other students, Kelsey Worth, Marcy Lavoie, Apostolos Larios, Brian Freiberger, and they formed Align Technology in 1997. And in 1998, the FDA approved Invisalign as a medical device for orthodontic tooth movement. And what made this unique is the use of CAD/CAM technology to stage tooth movement and to generate printed models for aligner fabrication. And so there were over 40 primary patents that were issued. And those patents, the vast majority of them expired in 2017, and that's why we've seen an explosion of clear aligner therapy. Different companies, whether it's in the past, it was Smile Direct Club or Bite or Candid, all sorts of different companies out there now. And so the user interface originally, this happens to be a more advanced user interface than the original one, but it was pretty basic. There wasn't a lot that you could do. You really didn't have communication, or you didn't really have the ability to move the teeth. A lot of times all you were doing was you were writing notes back and forth to a technician, hoping that they would understand what you wanted to accomplish. But the UI is really, really improved to the point where you have 3D control over all of the teeth. And you have a lot more information that you can get than you did from the previous UI. And as I've already alluded to, back in the day, of course, clear aligners weren't being used a lot because they required a full mouth impression, a PVS impression, where you had to capture all of the teeth. And I know for me, I received several rejected impressions, and you'd have to have the patient come back. And so now I think that the vast majority of us are using scanners, and they have an iTero Luminous scanner, which doesn't have a mirror in it apparently, and apparently it captures images faster. Do you have that camera, Brett?
I do.
You do? And any difference?
It's a lot faster. The focal length is a lot. It's further away from the teeth, so it's ortho, it's so much better. Restorative. We're working on that as far as it's FDA approved for ortho, but not FDA approved yet for restorative.
Okay.
So we're mixed in here with ortho and restorative, but I mean, as far as scanning the entire arch and palate, that's time and a half.
Yeah.
I didn't know what it was. But restorative, we're still working on. I mean, it's accurate, but it's just there's a lot of little things that we're working on. But it's a great scan.
Is it the same mechanism of action though, where it stitches together?
Yeah, it stitches them together. Yeah.
There's 6 cameras in it. Yeah. So.
And so it's funny because I had to reach out to and call Brett out because I was opening up my ClinCheck website, maybe I don't know, about a month ago, and Brett's face showed up on my ClinCheck. I was like, what in the world?
What?
They were advertising some sort of CE event or something. And so I was like, hey, I know that guy.
I didn't know it was on there.
Yeah, no, it was on there. And so in 2017, over 40 Align patents expired, allowing multiple companies to enter the market. Currently, Align fabricates 320,000 unique aligners a day, having served over 6 million patients and has 80% of the clear aligner market share. It's estimated that the global aligner market was $4.7 billion in 2021 and will expand at a compound annual growth rate of about 30% up until 2030. So when do I prefer Invisalign over fixed appliances? And you know, other people may have different parameters or different ideas, but for me, I like to use it, of course, on patients that have marginal oral hygiene, in situations where root morphology will make the patient more prone to idiopathic root resorption, patients that have spindly trigonal apices, root dilacerations. I like to use Invisalign on open bite cases without a significant skeletal component. I also like to use Invisalign on cases that are mild to moderate class 3 malocclusions as opposed to braces. Missing or undersized teeth in the anterior region, I feel like it's a lot simpler to ask Invisalign to open specific spaces rather than going back and forth with fixed appliances and opening space with open coil spring and putting closed coil spring back in and closing all of the space that you open. And then of course, patients with high aesthetic demands. So one of the myths is that you can't achieve significant expansion with aligners, and it has led to wide use and often overly prescribed interproximal reduction. And I know that initially when I first started doing Invisalign, one of the first things that I did at the time that we placed the attachments was perform quite extensive interproximal reduction before we even moved the teeth. Invisalign is most effective at expansion in the canine and premolar area, which is similar to fixed appliances. And the efficiency of expansion decreases from the anterior to the posterior. There has been a significant improvement in the expansion when Align transitioned from EX30 to SmartTrack material. And SmartTrack's just a BPA-free multi-layer polyurethane resin material. And the idea is that it delivers a more uniform force over time. And so, of course, the blue with the standard Align material, you would have a very quick decay in the force, would slowly come down. But of course, you deliver the aligners with SmartTrack, there's going to be an initial decay of the force, but it is pretty constant. And so an example of a patient that did some expansion on as an adult, this is just dental expansion. And a couple things I want you to know, and one of which is anytime that you have teeth that are overlapped, I think that it's very, very important that you communicate to the patient that they are going to get a dark gingival embrasure. And if this isn't communicated to the patient, it becomes an excuse rather than a cause. Now in this patient, we did treat her with aligners and we did achieve nice alignment. However, we do have some dark triangles. So if I was to retreat this case, I would do a little bit of interproximal reduction between 24 and 25 and 8 and 9 to try to move that contact point closer to the gingival margin so that we obscure the dark triangle. I know that there are some dentists now that like to use BioClear techniques, and that's wonderful. It's good to have that tool in your toolbox. But for me as an orthodontist, generally what we're doing in this circumstance is we're doing IPR.
When you look at that patient, she has a very triangular tooth shape.
Yes.
And so, hindsight being 20/20 though, I would think that would make sense to do a little bit more reduction to create less of a triangular shape.
Absolutely.
So you get a little bit less of that break.
Absolutely.
And when you're going to expand these patients, what are you evaluating as far as the biotype of the gingiva and the facial profile alone before?
No, I think that's a great question. Well, one of the things that we always want to evaluate is whether or not there is currently any sort of gingival recession in the posterior area and whether or not there is sufficient attached tissue in order to expand these patients. I think that the other thing that's important is having the right force system. If you tip the teeth out and you don't have buccal root torque on the upper, a lot of these times when you're overexpanding these patients, they're going to end up with some gingival recession. So we have Charmaine here, 30 years old. Her chief concern is that she's crowded. She has an orthognathic facial type. She does have VME, which she's unwilling to consider surgery for. Upper midline is coincident with facial midline. Lower midline is deviated slightly to the right. She has minimal overbite and overjet. She does have a little bit of transverse maxillary deficiency, and she has several teeth that have single tooth crossbites. And so she's moderately crowded on both the upper and the lower. So here's Charmaine, and here is her initial ClinCheck. One of the things I want to point out is this crossbite correction here. It's really important that if you're trying to correct a crossbite, that you don't have any sort of collisions between the upper and lower dental arch. Otherwise, the crossbite's just not going to be corrected. So oftentimes what I'll do is I'll intrude the teeth in order to correct the crossbite, even in circumstances where the tooth doesn't necessarily need to be intruded at the end, and then re-extrude the tooth. So just going through the ClinCheck, just looking how everything is lining up. I always hit play, and then I go through and I look at how the tooth movement is occurring by moving the slider at the bottom. Just gives me a better idea of the way that the teeth are moving rather than just watching play on here. And so composite images of the way that the teeth are moving, showing expansion in the back, primarily again at the premolar area. The molars are primarily just rotating mesial out in order to get some expansion there. So here she is at her first ClinCheck, or excuse me, her first refinement. Still pretty tight here, canine area, getting some decent expansion, lining up pretty well. This premolar tooth right here, it never had the right attachment on it. And so this premolar didn't get all of the way derotated. If you look, it has an optimized attachment. She needed a bigger attachment on that tooth in order to completely derotate it. So here she is, ClinCheck later, correcting the crossbite, getting everything dialed in. Of course, we have some IPR. When I do IPR, I generally do 0.1 less than what Invisalign is called for, so that I don't have excessive open contacts at the end of treatment. I don't really have an issue with teeth starting to collide and to recrowd during later stages of treatment. So just kind of cruising through everything, making sure that everything looks good. Has set up for class 3 elastics in the event that we are dealing with a posterior open bite, which is fairly common with Invisalign treatment because we end up with anterior interferences as well as plastic constantly interposed between the posterior teeth. And so here she is at the end, nice result, did achieve some expansion, not like crazy expansion, but enough that we were able to align the teeth and enough that we achieved a really good result for her. And so beginning, end, fixed retainer in place. So next patient I want to show is Sydney. Sydney is 14, almost 15. She had prior orthodontic treatment with fixed appliances, and she hasn't been consistent with retainer wear. And her chief concern is that her smile is narrow and her braces didn't fix it. And she's only willing to consider clear aligner therapy because she's in high school. And so here she is as she presented, not a bad orthodontic result, was probably treatment ended prior to getting on the upper and lower second molar, so those are out of occlusion. Midlines are pretty much coincident, a little bit class 2 over on the right, class 1 over on the left. Midline's going to be deviated a little bit over to the left, which is more indicative of a slight class 2 occlusion over on the left side. And so there's her smile, a little bit of dark buccal corridor. And then here she is after Align therapy. Now, we never really did get this upper second molar all of the way in occlusion, but there has been an improvement. We have a nice broad smile, and she was stoked with the outcome. So as I've already alluded to, one of the primary side effects of expansion is uncontrolled tipping, and this can result in maxillary lingual cusp hanging, resulting in an open bite. So it's really imperative when you are considering expansion that you also lift those lingual cusp of the upper molars in order not to have a hanging cusp and end up with an anterior open bite. ClinCheck for Sydney, pretty straightforward. One of the things that I would tell you guys to avoid is I would avoid these power ridges where they're side by side. In select teeth, it tends to be effective if you have one tooth, but when you have 4 in a row like that, all the aligner does stick out from the teeth and just cause irritation to patients' lips. So Invisalign, at the beginning of this year, came out with the IPE, which is Invisalign Palatal Expander. Attachments are placed generally on the upper first molars and the upper primary second molars, and each stage corresponds to a 1/4 millimeter of expansion. So just like an RPE, every time you turn an RPE, one turn would be a 1/4 millimeter. And so here's the video that Invisalign shares showing this Invisalign palatal expansion. It was just funny to me because, you know, I mean, look at how miserable this kid is getting the expander, and we're trying to cement the RPE with cheek stretchers in, but Dr. Walt here, he's got it figured out. He's going to give this patient this IPE, and everybody's going to be happy. My favorite comes up here in a second where he's showing mom how to turn the expander, and I think that you'll read her lips. And okay, so here we are. Oh, yep. So painful. There has to be a better way. So Dr. Walt's going to come in here and he's going to tell you about IPE. Now, what I will tell you is that in the limited cases that I've done, I haven't had a case fail yet where I haven't achieved sutural expansion. That being said, the primary difference is really compliance and its cost. It's about $700 in order to get an IPE. I think that's the rack rate. To do a Hyrax expander, for instance, depending on the lab, it can vary anywhere between $100 to $200. Of course, it's fixed, so you don't have to rely on patient compliance as much, but you still have to rely on mom and dad to turn the expander. And so this is Genevieve. She's 13 years old. Her chief concern was her teeth were crowded, and she wants Invisalign. And oh, by the way, she is leaving to the Marshall Islands to the Kwajalein Atoll, wherever that is, and she only returns to the States every 10 months. So if you're like me, you got curious, looked it up. It looks like there's an airstrip, some barracks over here, you know, maybe a few houses, but probably not an orthodontist on Kwajalein Atoll. So here's how she presented, pretty crowded on both the upper and the lower. And you know, this really isn't a face that lends itself well to extractions. And so the easiest thing to do, considering her circumstances and logistics, would have been to extract teeth, to extract the upper first premolars, let some driftodontics happen with the upper canines. On the lower, more than likely extract lower first premolars as well, let driftodontics happen. And then when she comes back, you know, after 10 months, go ahead and put either fixed appliances or Invisalign. And so her maxillary midline was coincident. Her lower midline was deviated to the left. She had a deep bite, a little bit of overjet. She had a class 2 subdivision left, so she was class 2 on the left side. Severe crowding on the upper, moderate crowding on the lower, restricted envelope of function, and therefore had a lot of chipping and wear on the edges of the incisors. And so my treatment objectives for her was to treat her non-extraction. Facial profile and lip position does not lend itself well to extraction treatment in this circumstance. Establish dental and facial midline symmetry, correction of the deep bite, properly incline the incisors to shallow anterior guidance, widen the dental arches, bring canines 6 and 11 into function, yada, 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 and basically ideally align the teeth. And so here we are, so the treatment plan, orthodontic expansion with IPE, hold the expansion for 9 months using holding appliances. And the way that these work is that you have the patient use a new one every day. So you're getting a 1/4 millimeter of expansion every day. And so for her, we were aiming for about 7 millimeters of expansion on the upper. So I stopped her at 28 and asked her to come back and let me take a look. IPR in the lower arch, wear some elastics, and then retain. And so here's the appliance in place. In this circumstance, the appliance, and I don't know why they don't extend the appliance back to the second molars. I don't know if it has to do with patient comfort, gag reflex. I'm not exactly certain, but you can see that the second molars are lagging behind the rest of the buccal segment. in a width dimension. Now, one of the things I will point out is that we know that we obtain sutural expansion, at least partial sutural expansion, by the diastema between 8 and 9. Now, this case is still a case in progress. So after we did the expansion with IPE, mom and dad lost their contract, and so this patient actually went into fixed appliances. And so here she is. Just put fixed appliances on her. I think it was like 2 or 3 months ago. She hasn't been in fixed appliances very long, but plan is still to treat her non-extraction. One of the things that I find interesting is that her facial profile is actually improved just from the expansion. And what I think, the reason I think that is because I think that these cusps are probably hanging down, deep bite, corrected a little bit, so she has a little bit more lower face height. So another thing that we commonly hear with clear aligner therapy is that you can't close extraction spaces. Now there is a caveat to that. I never try to close extraction space in the mandible with aligners just because dense cortical bone does not lend itself well to extractions. In particular, if you're extracting second premolars, there really isn't any way that you're going to move the roots of the lower first molars far enough mesially in order to avoid a tooth that's just completely tipped forward. As a pushing appliance, Invisalign is very effective at both controlled and uncontrolled tipping. To bodily move teeth, you need to direct a force at a tooth center of resistance, or you need a force applied to a tooth and a counteracting moment to prevent the tipping moment induced from the applied force. Now, with respect to where the center of resistance is, it depends on the root length and obviously periodontal condition as well. In this circumstance, we have a long root, healthy periodontium, and in this circumstance, the center of resistance is going to be closer to the clinical crown. In this circumstance, where we have some periodontal disease, we have nice long root, center of resistance is going to be closer to the apex of the root. Patient that has had some resorption, this circumstance, healthy periodontium, again, the center of resistance is going to be higher. So a moment is the tendency for a force to produce rotation. So when you push on a tooth, for instance, there's going to be a tendency for that tooth to tip as well as move forward. So a moment is found by its direction following the line of action around the center of resistance towards the point of origin. Let me go back here, if it will let me. Oh, maybe it won't let me. Excuse me for a second, guys. Okay. It is determined by multiplying the magnitude of the force by the perpendicular distance of the line of action to the center of resistance. And so as we're closing space, we want translation, obviously. All PDL must be uniformly loaded with a force. To avoid undermining resorption and hyalinization of the periodontal ligament, the force level needs to be between 100 and 150 grams. And I couldn't tell you for the life of me why orthodontists use grams, but we just do. We don't use newtons or anything like that. From a practical perspective, it's impossible to deliver a force at the center of resistance, so you have to apply a counteracting moment. And so, as an example, I have a patient, Ashley, here. She's 36 years old. Her chief concern is that her dentist told her that she was going to lose a baby tooth and her teeth are crowded. And so she has increased facial convexity, a deep bite, she has increased overjet, she's missing tooth number 12, has a peg form number 4, class 2 molar relationship bilaterally. She's crowded a little bit on the upper, more crowded on the lower. She's narrow, she has dark buccal corridors when smiling. So here's the initial, here are the instructions, which we can't really see to the technician, but basically asking them to extract the tooth and close the space. So here is the animation of the anticipated tooth movement. Pretty simple. Here she is after she finished the initial set of aligners. And we really didn't get where we wanted to be over on this left side. We mostly have tipping, and that's a Dr. White issue. I didn't program enough mesial root tip into the movement of this first molar. But overall, the case is going well. One of the things that I always like to do is when I'm doing a refinement, I always like to compare the scan bite to what I see clinically. And the primary reason is just to make sure that the scan bite is accurate so that as I'm treatment planning, that I know that that's actually how the teeth are meeting. So comparing occlusion on this premolar, for instance, comparing occlusion on this one, looking at incisors so that we know that we have an accurate scan bite. When I'm submitting a refinement, basically what I have a list of kind of common things that I want to try to achieve or instructions that I'm giving the technician. We always check spacing in between the teeth. We always check to see which teeth are out of contact. And then generally we chart which attachments we want to remove. And anytime that I have optimized attachments, those are usually attachments that I'll remove at the time of refinement. Yeah. I don't. I know you do. I'm trying to get my TC on board.
Just to show patients, if they're going to have laterals or whatever, to show them what it would look like. You don't ever have a need to use it.
It's not that I don't have a need. It's a matter of getting everybody on board. It's hard when you have a TC that's used to doing something, the treatment coordinator that's used to doing something a certain way, to go through the extra step of actually having her do that.
Practice app too.
Yeah.
I know your photos are always camera and whatnot, but you have to use the practice app to upload them as well.
Yeah. No, I want to stop by, and I know that you and I talked about this.
Check though, because you have those photos in the clin check.
Yep.
When you do the simulation, you can actually see the simulation in their face, which is really helpful. I feel when I'm planning, it's like to see the smile. If you're intruding teeth, or extruding teeth, you can see what it's doing to the facial.
Yep.
To the aesthetics.
Yeah, I mean, in particular, I think that's really useful as a restorative dentist. I know that you use it quite a bit. I went over to Brett's office and toured around. I mean, he's got more Invisalign hardware than I do, and he's a restorative dentist. Yeah.
Putting buttons on crowns.
Yeah. Monobond is the way to go. Monobond. Yeah. So I wouldn't use porcelain etch. I don't even know what the material is. And I assume, Sean, that you're using the same thing for crowns, monobond? Yeah, monobond, we don't have issues with them coming off even on zirconia. I couldn't tell you what it is. It's expensive. It's probably, I don't know, $200 a bottle. It's very expensive, but you don't have to deal with hydrofluoric acid or anything like that. The exact way that they do it, since I don't place the attachments, I couldn't tell you. Is it etch, traditional etch, rinse, monobond? I think that's what it is. And then you rub the monobond in for about 90 seconds. You don't etch it with anything, not even just with phosphoric? No, okay. Yeah.
Is it monobond etch and prime, or is it like just monobond?
It's just monobond, not the monobond etch and prime.
Okay, so
I'm almost 100% certain.
well, it makes sense, because I use that inside my crown, the monobond etch and prime, but then someone had told me about the monobond.
Yeah, they have two versions, and one of them you don't want to use. I believe the one you don't want to use is the etch and prime, right? Yeah, okay.
So you just use like a regular etch? Or you don't-
Well, I believe that my assistants do, but it sounds like Sean doesn't think, or it doesn't sound like it's necessary.
Okay, is it 90 seconds? Or how long do you apply it for? The monobond?
Honestly, I don't remember.
My understanding is it's about 60 seconds. So you put it on and you just agitate it with a micro brush is the way that I recall it. You have to be kind of careful because if it gets on the tissue, it turns the tissue like a really blue, purple color that patients aren't a big fan of. So we have Holly here, 21 years old. Her teeth are crowded. She's in on class 2 over on the right, full step class 2 over on the left. And obviously deep curve of SPE, over erupted 23 through 26, narrow on the upper, narrow on the lower. And so in this circumstance, we actually elected just to remove one premolar over on the left side. and treat the opposite side that was in on class 2 just with elastics. One of the things I really like about this ClinCheck that I think that you want to watch when you have large spaces is you want to make sure that you have a complete wrap of plastic around the teeth. And so you'll notice here that this molar comes forward. Before this one starts to come forward, you have a wrap of plastic around the distal of that tooth. Here she is fairly recently. We've closed the space. We did a better job in maintaining root position on this molar than we did in the previous case. She's almost done. I don't think she's quite done yet. There's some tidy up stuff that needs to be done. Obviously some cosmetic considerations with 8 and 9, maybe a little enamel-plasty, maybe some composite, maybe even indirect restorations in your office. So as I've already stated, one of the things that we can't do is we can't really use aligners to close extraction space on the lower. Circumstance where we have an adult patient, really crowded on the lower, periodontal condition and just position of the teeth really doesn't lend itself well to just kind of dumping the incisors forward. Failing root canal, got a post in tooth number 30. She had that tooth extracted. She had upper premolars and lower second premolars extracted, and close the space. Implant placement here. I know this is a pano, but yeah, this was not placed by a surgeon in this room, but it just looks awfully close to that premolar. Another myth that I hear a lot is that you can't fix large class 2s. And you can, it just requires that you kind of have different treatment techniques in your toolbox. So here's a guy, doesn't want braces, doesn't like his overbite. He's a full step class 2 on both the right and left, not real crowded. You can see from the Ceph, not a ton of overjet. Upper incisors are very upright. In this circumstance, we used a Carrier or a motion appliance. Now I wouldn't use a lingual arch. I would use like a lower Zendura Essex retainer with a cutout for elastics. Distalize the maxillary buccal segment, and then it becomes a very straightforward case to treat. This patient was treated with, I believe, 22 aligners after we achieved class 1 with the motion appliance. And case turned out well. You can also use functional appliances with Invisalign. One of the functional appliances that works well with Invisalign is a Mara. A Mara has an upper mechanism, so it has an elbow on the upper, a cam on the lower. When patient bites down, they have to posture their jaw forward in order to get their back teeth to come together. So this patient, Mia, was treated with a Mara. Invisalign does have a mandibular advancement attachment or an option. I've only used this a couple times. I didn't find it effective. It didn't work for me. It doesn't mean that it doesn't work for some people. I found that these were really distorted, and it was just another reason for the patient not to wear their aligners. With the Mara, patient can't take it in or out. They just have to have it. So day of Mara removal, class 1 here, a little bit undercorrected here. I wish we would have got a little bit more class 1 over on this side. And then her ClinCheck, pretty straightforward. It looks like we have 27 or 28 aligners. I'm on 1 week changes. I don't do 2 weeks. But yeah, real straightforward case.
Have you tried the blocks? Have you heard the blocks?
I have used the blocks. The only blocks that I know of, does Invisalign have blocks? The only ones that I know that have blocks are Angel, but yeah, I would be interesting to hear.
I don't know if they're FDA approved yet for here, but
yeah,
I was at a meeting where they've been doing that.
Yeah, those wings just they don't work.
I know.
Yeah, I mean they
have blocks that just force them into it.
Yeah, I know that Angel has the blocks, and it's something that they've used for a long time, but. I've heard this as well, and I've asked my Invisalign rep about direct printing aligners, and she didn't seem to have any idea that that was happening. Yeah, yeah. No, I mean there is going to be direct printed aligners for sure. I mean direct printed night guards. I mean it's just a matter of time. So Lainey here, she had her primary concern is she hit her front tooth and she has an underbite and pretty straight facial profile, really pretty little gal. But you'll notice over here, she's a full step class 3 over on the left, anterior crossbite. Instructions to the technician, we want to widen both arches, eliminate palatal contacts on upper 4, 5, 6, and 7, so the entire buccal segment as we're doing expansion. Achieve a class 1 molar and canine relationship. This is a typo. This should be use class 3 elastics and lower sequential distalization. Slow down tooth movement on tooth number 8, the tooth that was traumatized. So we'll ask the technician to slow down to 0.15 millimeters per tray. And then we want to add some large attachments to the upper second molars in order to disclude the bite. So here are the composites as well as the anticipated movement over on her left side where she's a full step class 3, complete wrap of plastic showing distalization of the lower posterior teeth. And then here she is, she's finishing up treatment right now. But we were able to achieve a nice class 1 relationship, obviously get her out of anterior crossbite. Tidy up work needs to be done on the second molars to bring those in occlusion, but overall the case is going well. So another myth, in fact, I was talking to an oral surgeon about this last night. He wasn't aware that you could do orthognathic surgery with patients that are in Invisalign or other clear aligners. So we have Kaya here, she's 34 years old. Her bite has changed over the last 10 years. And we're looking, she has quite a bit of VME. Also some mandibular asymmetry for sure there. Real hyperdivergent, open bite tendency. Fixed retainer in place, so did okay maintaining everything on the lower. A little bit collapsed on the upper. And here's occlusion. So anterior open bite, and so then it becomes an issue of chicken and egg. Is the anterior open bite caused solely by the clockwise growth of the mandible, or is there some sort of tongue habit or something? And it's probably a combination of the two. So her clean check, we're getting her ready for surgery. Just trying to level out the arches, making it so that we don't have more than 3 planes that the surgeon has to deal with in order to align. And then of course, what Invisalign will do for you at the very end is they'll show you the anticipated surgical movement. Pre-surgery, close to the clean check. And really, the kind of the difficulty with Invisalign patients was figuring out how you were going to place a splint and you were going to put them in IMF. And so here on the upper left, we have a splint in place. Looks like there's some buttons in the back, probably wore some elastics. There are some surgeons that will take the aligners and they will articulate the aligners together in the planned surgical position after they do model surgery. But now most of the surgeons are actually doing all of their planned surgical movement using CAD/CAM, and then they're having the splint direct printed as an example here. And so IMF, all sorts of different ways you can do IMF. This is kind of barbaric in certain circumstances where you have hooks in between or posts in between all of the brackets, rubber bands being worn. I believe there's a splint interposed there. Here we have arch bars. Down here, it looks like what we have going on is we have some bone screws, and then we've kind of rigidly fixated the upper and lower jaws using some sort of wire material. And then this is interesting because we have a passive wire that was bent, and then we have posts that are in between the wire, in between each tooth with composite pads. But now, really what the surgeons like to do is they like to place TADs. So we have 4 TADs in place, and where they make the osteotomy, basically they'll just take a wire and they'll bond it across the osteotomy site. So here she is 1 month post-surgery. I don't have occlusals because she couldn't open wide enough. And then here she is 6 months post-surgery, kind of detailing everything out, having a hard time getting occlusion over here on the right side. So we have some buttons that we're having her wear some elastics from upper to lower. And then here she is at the completion of treatment and 19 months in treatment. So next case I want to show you is Ashley, and Ashley's kind of interesting. She is how would I say this, Nikia? You're just shaking your hand. Yeah. Here's Ashley. She doesn't like her flared teeth and her overbite. She obviously has this asymmetry in the upper dental arch. She has VME primarily over on the left side. And you can see this here. She's missing tooth number 14 as well, deep bite in the front. And so her medical history is non-contributory. She has increased facial convexity due to a retrognathic mandible. Her chin point is asymmetric. It's deviated to the left. We've already talked about the asymmetric maxillary excess, vertical maxillary excess, and then a midline discrepancy as well. She had 8 millimeters of overjet, occlusal plane cant, bilateral class 2 molar and canine, and then moderate upper and lower arch perimeter deficiency. Cephalometrics basically kind of confirms what you can see just by looking at her deficient lower jaw, lower incisors flared forward, upper incisors properly positioned, and a little bit of an open bite tendency, a little bit of an elevated mandibular plane angle. So treatment plan for her was clear aligner therapy in conjunction with double jaw surgery. Need to wear aligners 22 hours a day. You have to use chewies at least 20 minutes a day in order to stimulate blood flow to the teeth and to also make sure that the aligners are completely seated over the top of the attachments. There would be obviously some pre-surgical orthodontic leveling, some post-surgical orthodontic detailing. We would detail and retain. And here is her first ClinCheck, basically just showing that we're leveling the upper arch, kind of lining everything up in preparation for her surgery. Here she is 10 months into treatment, still class 2, still a little bit of a deep bite, more class 2 certainly on the right side than the left. Here she is pre-surgery, she's ready to go. And then here she is post-surgery. So similar way of securing or basically splinting the osteotomy sites, just a wire bonded between the lateral incisor and the canine. TADs have been removed, but she did wear elastics from TADs into the splint. And then here she is at the end of treatment. Now, this patient, to me, this is a great result. Obviously, there are some things that need to be done cosmetically with these lower incisors. But this patient isn't worried about that. She's worried about this. She's worried that this tooth is rotated a little bit more than the contralateral second molar. Final pano. Cheated on the ceph because Frankfurt horizontal, which is this line right here, isn't even between, or it's not in the same plane as right and left. Class 3 patient, treated with aligners. Just doing the setup prior to surgery. Surgery at the end. Interesting with this patient is he also wanted to maintain some of his chin prominence, so he also had a genioplasty forward. Another thing that I hear a lot is that you can't extrude teeth with aligners, and I think that the idea is that since you have a smooth convex surface, you really don't have anything to grab a hold of in order to pull the teeth down. And the keys really to correcting open bites and to extruding teeth are in staging and attachment design and placement. And to predictably extrude the teeth with plastic, you have to have visible space on either side of the teeth that you're going to extrude. If you don't open space up, the teeth aren't going to extrude. And you need to use the largest horizontal beveled attachments that will fit on the tooth, and they need to be tapered to the gingival. Always need to over-treat as well. It's cartoonodontics, and so you have to basically over-engineer the product in order to get the desired outcome. And it's also imperative that you treat the etiology of the open bite for post-treatment stability. A lot of these patients have tongue thrusts, Again, it's chicken and egg. You don't know whether or not the tongue thrust is present because the open bite is there, or is the open bite caused from the tongue thrust. So patient, large large beveled attachments on the upper, slash attachments on the lateral incisors, optimized extrusion attachments on the lower. If I were to do it again, I would use larger attachments on these incisors. These are the ones that Invisalign will give you by default, are the optimized extrusion attachments. And then really, really large bite blocks on the upper first and second molars to assist with intrusion of the upper first and second molars. Just cruising through the ClinCheck, checking everything. Again, an area where we have an optimized attachment that I think that we would have been better off with a conventional attachment in order to get that rotation all of the way out. So bringing the teeth together. And so here's Laura. Laura has an open bite, obviously. And you can see large attachments, upper, pretty large attachments on the lower. Still in treatment, this patient, and I apologize, since I'm relatively new to the community, I don't have a lot of finished cases. I have to borrow some from Dr. Vandevanter, but you guys get the idea. So when I'm looking at a ClinCheck, I have kind of a standard way that I like to look at ClinChecks. The very first thing that I like to do is I like to make sure that the scan is accurate. I want to make sure that it's the correct patient, the dental anatomy is undistorted, the terminal teeth are captured sufficiently. Another thing that is really, really common is that you'll see ClinChecks where the tooth movement just disobeys the laws of physics. You're not going to get the desired outcome if you show an entire arch being distalized all at the same time. So those are things to pay attention and communicate with your technician about. The next thing I look at is vertical. So we're exaggerating open bite and deep bite corrections, just like you would with a reverse curve of SPE arch wire in any patient if you were doing fixed appliances. Are the attachments appropriate for the desired tooth movement? And are bite ramps present as you prescribed? The next I look at is transverse, overcorrect just like you would an expanded arch wire. And is there sufficient root torque in the buccal segments to avoid uncontrolled tipping? Last, or one of the last, is AP. For greater than 3 millimeters of sagittal correction, I always do sequential distalization backed up with elastics. So on my class 2 or class 3 patients, I'll always, if the correction is greater than 3 millimeters, I'll sequentially distalize. Want to make sure that your cutouts for elastics and slits are at the appropriate spot. And lastly, want to check occlusion. And with the exception of open bite corrections, always want to ask the technician for hard red posterior occlusion, and you want the anterior teeth either out of occlusion or in light green contact. Lastly, overcorrections. You want to make sure that you have if there are any rotations that are present, are they overcorrected by at least 5 degrees? If you have large spaces, a technique that I'll often use is I'll prescribe virtual interproximal reduction. So I'll tell the technician to do IPR in that area, and I won't actually perform it, just to have a nice snug contact in between the teeth. And then you want to make sure that you have enough passive trays and overcorrections. And it's one of the things that you want to ask your technician to do for you. If you're never going to, I shouldn't say never, but rarely are you going to get where you want to be, get to the target with your initial ClinCheck. And so you want to make sure that your patients have aligners to wear, clean aligners, while they're waiting for aligners to come back from Invisalign. So we always ask for 4 passives and 4 overcorrections with every ClinCheck. Tell the technicians that you want 0 collision tolerance. So oftentimes technicians will kind of move teeth through each other. That's not going to happen. I would try to avoid IPR on the first ClinCheck unless you absolutely have to. Not uncommon. Most of my Invisalign patients get IPR. But I try to do the first ClinCheck without any sort of IPR. If you're significantly expanding, tell the technician you want them to remove Powell contacts on upper premolars and molars, and you want hard red posterior contacts. So kind of cruising through a ClinCheck here. Actually, I'm going to go to the next one. Cruising through a ClinCheck here. What I'm looking for is I'm just, again, looking at things vertical, transverse, AP. This patient, we are electing to do an indirect restoration on tooth number 7. So we're elevating this tooth to get gum lines to match. Then if we're going to intrude this tooth, we have to make sure that for every action there is an equal and opposite reaction. So we want some sort of attachment on this upper right central incisor in order to provide some sort of extrusive force. So I'm just going through here, going to choose the attachment, horizontal beveled attachment, usually a 4 millimeter on the upper central incisors. This is something that's new as well that Invisalign didn't say anything about. Can you describe this, Brett? This is what they told me, this is a attachmentless activation.
Right.
Do you know what that means? I have no idea.
It's just the plastic technology has changed as
Uh-huh.
far as the surface contacts of the plastic, which is hard to explain really as far as like, why weren't they doing this before, but it's really just about their plastic activating the teeth more so than.
Is it because of the rigidity of the plastic in certain areas? Like is
Yeah,
the,
so for like diastema closures, you know, they can do it without attachments, without double attachments. They can use these attachment-less.
yeah, I don't know that I would do that. I would always have a great big attachment. I'm old school.
Yeah, I mean, you can swap it out and say,
Yeah.
hey, I don't want that.
Yeah.
It's like their newest thing. And I don't quite trust it just yet.
Yeah.
I
Yeah.
can make a comment that I appreciate all the things you're saying because it's like refreshing for me that all the stuff you're talking about, like, oh, yeah, everything you're saying.
Oh,
is
well,
like
thank you.
100%.
I appreciate that.
I back it up 100%.
As I've already alluded to, one of the things that's kind of new in clear aligner therapy is we have all of these new companies coming out, and one of the companies that I'm using a little bit more is Angel Aligner. Angel has been around for a long time. They've been around actually almost as long as Invisalign. It's a Chinese company. They have the dominant market share in Asia and a lot of Europe. But until fairly recently, they weren't really present here in the US. But there are some cool things about it. One of the cool things, it's relatively minor, but one of the only emergencies that we have to deal with patients that have clear aligners is buttons coming off for elastics. And so Angel has integrated these buttons into the plastic so you don't have to worry about the attachments coming off of the teeth. So the UI looks very similar to Invisalign. I'm sure that's by design. Almost the same. The attachments are essentially the same. They don't use as many optimized attachments. The optimized attachments are individual attachments that are designed for certain tooth movement that Invisalign's used with their algorithms. But yeah, pretty straightforward. One of the things that I wanted to mention that I've seen a few times here, this is completely off topic, but I've seen this, and I'm sure that Tom has seen this as well. With these type of fixed retainers, this happens to be a twisted fixed retainer that's bonded to every tooth. If you have a patient that has one of these on, they need to come off. And it's not the braided ones, it's the ones that they're twisted. If patient bites down on something and it distorts this wire, it can induce a torquing movement that can move, that essentially becomes an orthodontic appliance that can move a tooth forward, causing a large dehiscence. So if you happen to run across this, I just saw a patient, I think it was last week where this was the case. If you happen to see this, these need to come off and they need a removable retainer or they need some sort of different fixed retainer other than that. I want to thank you guys for inviting me today. And if you need to reach me at all, email address, cell phone number. And thanks again to Dr. King and to Kevin and all of the folks at PSP for the invitation to speak today. And that's all I have.
Thanks so much.
Yeah. Any questions? Sweet. All right, thanks guys, appreciate you. Yes, ma'am.
How do you decide between fixed retention and removal at the end?
And I think that you know this from our office, as a matter of standard procedure, we always do fixed retention on the bottom, unless a patient declines it for whatever reason. If there's a hygiene reason, then yeah, maybe not place a fixed retainer. But As I'm sure that all of you have seen, the area where you have the most orthodontic relapse is the lower anterior teeth. And it's the reason why is because expanding lower inner canine width is the most unstable tooth movement. And they've done lots of studies. In fact, the studies were done here in Washington, Little and Rydell. They're very classic studies where they've shown that the canine teeth are just going to continue to collapse in. As a consequence of that, anytime that we're doing any sort of expansion lower anterior, I would prefer to have a fixed retainer. I'm not a big fan of bonded retainers to every tooth. There's a couple reasons why. One is that it becomes a problem because a patient won't necessarily be aware that the composite pad has come debonded from the tooth until the tooth moves. Patient returns to your office and it's your fault, right? You have a retainer on the lower that's just bonded to a canine, you know when it's off. So that's one reason why I wouldn't use a bonded retainer to every tooth. There are circumstances where maybe I would, like a patient that had a lower incisor extracted, or there were perio concerns or something like that, where you would want to splint all of the teeth together. But in general, I'm just not a fan of doing fixed retainers on every single tooth on the bottom.
Is age ever an issue? Like someone who's like, let's say you're treating someone who's 60.
I think that it wouldn't necessarily be age as much as it would be, would there be a periodontal benefit to the patient by splinting all of the teeth together? I mean, maybe you guys are seeing something that I don't see on the other side, where these fixed retainers are causing some sort of issue. But from what I've seen, I really haven't seen a significant issue. What's that? Sometimes, yeah, sometimes we'll do overlays as well. If I have a patient that had extractions on the lower, or there was significant labial displacement of the lower incisors, I'll do a fixed retainer, but I'll still back it up with a removable retainer over the top. Mm-hmm. Yep. Yep.
Because there was a case that we had talked about, again, making it just a removable retainer.
Was it a patient that we treated in the office, or?
Yeah, it was one that Camille treated, I think, and then she had like internal resorption, she went to Dr. Co, and then was actually doing something new probably, so.
All right. Yeah, I don't recall the patient.
Yeah.
Yeah. All right. Thank you, everybody.
Thanks, man.
Not really.
So just a quick plug for our next meeting, Michelle Calvier she'll give us an update on a lot of important issues, including maybe what's up with things like expanding function, coming down pipe will be. It's great, I think, time out of schedule. Sometimes Cindy Paul will come with her to present this kind of update on things that are happening legislatively in the state. So I'd love it if you guys come make it and support Michelle at the next meeting, okay? See you guys in October. Thank you.
Thank you.